Ele pegou, esse cara foi o professor. Ele falou assim, a tua cureta vai ser a melhor do Brasil. Eu falei, para, filho, para. É as primeiras. A sua cureta vai ser a melhor do Brasil. O cara profetizou e para a honra e glória do Senhor, mais vende no Brasil, não tenho dúvida nenhuma, que é a nossa cureta. Então foi assim que surgiu a linha Milênio.
Hoje, a grande demanda de produtos são produtos minimamente invasivos, então são produtos muito mais delicados do que os produtos que eram utilizados há anos atrás. Trabalhamos com ligas novas de metais para diminuir o peso do material. Então são atenções que nós temos que dar ao mercado e buscar sempre antecipar essas necessidades e demandas do mercado.
Nunca se esqueça da nobreza da sua profissão. A odontologia tem o poder não só de cuidar dos nossos sorrisos, mas de devolver o sorriso para muita gente que já não sorria. Então nunca esqueça disso, não desista, não esqueça o brilhantismo que está na sua profissão.
Bom, mais uma vez, boa tarde a todos. Iniciando mais uma apresentação. Mais uma vez, obrigado à professora Carol pela excelente apresentação. Nosso orgulho aí de formação aqui na nossa faculdade, hoje minha colega de trabalho. E agora eu queria apresentar para vocês um professor que a gente conheceu em 2017, durante um congresso na Alemanha, e em que ele nos mostrou, na época ainda não tinha no Brasil, o EQA Forte, que é o ionômero da GC, um dos principais ionômeros, a última geração de ionômero de vidro, né, que nós temos, mais estéticos e mais resistentes. E então ele é um dentista da equipe da GC, desenvolvedor desse material. E então, antes de eu passar a palavra para ele, eu gostaria de falar um pouquinho do currículo dele. O professor Raduslav Asparuhov é graduado com honras pela Faculdade de Medicina Dental da Universidade Médica em Sofia, na Bulgária, em 1998. É especializado em dentística estética e dentística de mínima intervenção, e na sua prática, e trabalha na prática privada em Sófia desde 99. E a partir de janeiro de 2003, ele se tornou um consultor da equipe europeia da empresa GC, e também é um membro fundador da Bulgarian Society of Aesthetic Dentistry, a partir de janeiro de 2007. Desde 2009, já lecionou mais de 300 cursos, não só na Bulgária, como fora, como esse, né, para mais de 3.000 participantes. So, that's an honor for us to receive Dr. Raduslav, a friend that we met first time in Germany, and now it's a great opportunity that we Brazilians dentists have to know your job, to know your excellence. So thank you very much, Dr. Raduslav, for your kindness to be with us today. So take your time and we will attend in your presentation. I will try for who doesn't speak English, I will try to sum up some parts of your presentation, okay? So I ask if it's possible for you, if it's not a problem for you, to speak a little low, even if we need to pass some minutes after the time for who speaks English but is not fluent to understand their presentation. Okay, thank you very much.
Okay, thanks for having me. Thanks for the invitation. It's a real honor for me to participate in this Congress and to present the topic of new technologies of glass ionomer and glass hybrid materials. I heard your presentation when you presented me. Although I do not speak Portuguese, I hardly understand, but I noticed some of the things about me. I mean, as you said, I am born and raised and graduated dentistry in my hometown of Sofia. This is a picture of my hometown. I do not have much to say about me. The 25 years of my professional career so far, you can sum up in 7 or 8 sentences. But I really need to point out that I am consultant for GC Europe for almost 20 years, so I am a little bit biased. I am trying to pass that and be as objective as possible. So this year I'm also a member of Bioemulation Group. That is a group of great professionals. Most of my professional mentors are already in this group. So I'm really, really happy to share and the knowledge of such excellent dentists and technicians altogether. I also need to apologize for my English because it's not my mother language, and obviously I do not speak that well, but I hope it is going to be understandable for everyone. And I will try to speak a little bit slower, so you can translate whatever you need, but if not, you can always ask the questions afterwards in the Q&A session. So every time when I start the appointment with a new patient or with a new appointment with a patient, I am trying to select a restorative strategy, because nowadays, more than ever, we have a different type of methods, different type of materials that are available on our market and in our practices, and it is really, really difficult to determine which one is most appropriate to use in each clinical situation. So in all those cases, I am trying to put everything on the scale, to put all the benefits, all the shortcomings of the materials, so I can select the one that it is the most appropriate for this case, for this patient. And today, because I saw that Carolina was talking about evidence-based dentistry, I will try to give as much as possible information on the, let's say, material properties and how we can select the right tools, but not the right tools in any situation, but the right tools that are working in our own hands, and the right materials, the right tools that are designed specifically for these patients. Because every time we start the treatment, we should put the patient in the center of the restorative strategy. We should address his needs. So what is the most important thing that we need? Is it strength? Is it aesthetics? Is it the speed of work, or it is biocompatibility of the materials? What is the factors that we should consider? Can we isolate? What is the patient compliance? What is his risk of caries? So every time I sit in front of the patient, I have to take into the account, take into the consideration all those factors, so I can choose the best one in this specific case. So when we are looking at the current market, we have different kinds of materials, and in Bulgaria, probably as anywhere else in the world, the most popular materials are the composites. And the composites, they come with respective adhesive systems. And then on the other end of the scale, that is the glass ionomers. And very often they are perceived like rivals. They are perceived like the, let's say, people using mostly composites do not care much about glass ionomers and vice versa. And for me, this is something that we should try to correct, because it is like if I'm left-handed, so let's forget my right arm, or the opposite. No, they should work they should work together. They should work in synchronicity. So very often I'm using both kind of materials in the same restoration, trying to take the advantage of both of them for different reasons. Of course, there is no ideal material, and both of them, they have different shortcomings, different downsides, and the other group is actually taking some steps and some measures to counteract those shortcomings. So also the producers of the dental materials, they also try to help and reduce those shortcomings, those faults. And that's why the glass ionomers were tried to be improved with adding resin into them, and thus becoming a new group called resin-modified glass ionomers. Of course, adding resin to the glass ionomers improved the strength, improved the aesthetics, but the biggest advancement and the biggest field of application of resin-modified glass ionomers is still for luting cements. They are not so much for the restorative practice. And then there is another approach trying to adjust the properties of the composites, adding polyacids to them, created another group called polyacidic modified composites, also known as compomers. However, adding polyacids to the composites actually created much more of a problem than solving one. So basically, they can be perceived as, let's say, inferior composites, because they still have all the shortcomings of the composites. Without their aesthetics, without their strength, they still need adhesive system, and they are not as strong as the composites themselves. So lately, 5-6 years ago, a new group emerged on the market, and this is glass hybrids. So the glass hybrids, I will spend most of the time today to try to explain what the glass hybrids are, because very many people do not understand that they are completely separate group. Yes, they sit on the history of the glass ionomers. They use partially glass ionomer technology, but they are improved in so many ways, so much improved qualities, so they can be qualified as a separate group. So when we are talking about longevity, first of all, the goal of my restorative treatment usually is not to have a very, very long-lasting restoration. Normally, my goal is to have the same tooth restored as minimally invasive as possible, so the restoration, when they fail, I can replace easy with another one, very often without even extensive preparation. But when the people are choosing restorative materials, they very often look at this chart for longevity. And to my surprise, there is a study made in Sweden that the most successful type of restorative material is actually amalgam, because they can last up to 16 years before, and that is average, before they need to be replaced. Composites and glass ionomers respectively have 6 and 11 years of life. So this is, for glass ionomers, is something to be expected, but for the amalgam, I need to clarify that every time I remove an old amalgam, I usually detect a crack and a problem underneath that needs to be to take a step further. Very often there is a need to reinforce this cavity, which is not the case when I'm removing composite or glass ionomer. Luckily, amalgam is going. It's going away, and it is something that was decided 2015 with the Minamata Convention, and by the next decade, the amalgam is going to be phased out in Europe anyway. European Union for sure, probably most of the European countries, other European countries as well. So that's why FDI and World Health Organization, they started looking for an alternative to the dental amalgam. We need something that it is as cost-effective as amalgam, with more or less the same time needed for the restoration, and giving the same longevity. So at the moment, there are only a couple of proper alternatives to replace the amalgam, and one of them was recently selected by the World Health Organization as an essential dental material. This was published a few months ago, when glass ionomers were selected as an essential dental preparation. The other two are actually fluoride for the toothpaste and the silver diamine fluoride. So the World Health Organization is actually perceiving glass ionomers as a cost-effective alternative of amalgam, and because of the unique caries preventive properties, they are so unique, so make them superior than any other material that it is available on the market. Of course, there are being other materials in development, but it will take a little bit of time for them to appear on the market. So that's why I decided to focus on the one that we already have, and I will start with the glass ionomers. So talking about the glass ionomers, I need to point out in the beginning some of their key features. So the glass ionomers, they have the same CT as the enamel, or not the same, but let's say pretty close to the enamel, and also to the dentin. They do not shrink, or whenever there is shrinkage, the stress is so low so we can neglect it. They have a very high fluoride release, and they can be perceived as a self-repairing material, because the bond to the tooth structure is self-repairing. So basically, the glass ionomers are moisture tolerant. They are water-based cements, so the need of to use the rubber dam is optional. It is whenever there is excess water, it is going to become part of the cement itself, part of the restoration. So that is a very big advantage when we have preparation that it is subgingival, or the procedure should be shorter and we do not have enough time to do a proper isolation. On the other side, the glass ionomers have a chemical bond to the tooth structure. So this is usually described as a ion exchange layer. I will show a couple of slides later on, but it is extremely important to understand that we do not need to open the dentinal tubules. We do not need to dissolve the enamel prisms. So even when we do not have enamel, or the enamel is aprismatic, or the dentin is sclerotic, we can still rely on durable adhesion because of the ion exchange nature of the bonding itself. And last but not least, the glass ionomers can be perceived as tooth-friendly materials because they can be used with partial caries removal, and that is pretty much in line with the highlight of the Congress, because this is basically the basic of IRT treatment. So I will try to show a couple of studies that are showing that we do not need to do a full and complete caries excavation. Very often that would lead to complication from endodontic point of view. So basically the glass ionomers are always two components. There is a powder, which is aluminum silicate glass particles with high fluoride content, and there is liquid, which is usually aqueous solution of polyoxanoic acid. The ratio between the powder and liquid is always specific for each application, and very often when the material is in capsules, they are separated prior to activation. The setting reaction is a little bit different from conventional glass ionomer cement than the one from resin-modified glass ionomer, but with conventional glass ionomers, it's basically the matrix is formed by the dissolution of the surface of the glass particle in the acid, and the positive ions, calcium and aluminium, are released into the solution and act as a crosslink with the acid polymer to form a rigid matrix. Fluoride ions that are released are available for uptake on the adjacent tooth structure, and then they protect not only the tooth that carries the restoration, but also the adjacent tooth. As a result, we have a cement that it is made of glass particles that is surrounded and supported by a rigid matrix. With the conventional glass ionomer cements, we have autocure reaction, which is actually chemical reaction that continues for a longer, prolonged period of time, and especially the slow setting materials we need to protect at the earlier stage, because they are very susceptible to water uptake or water loss. So we should do a proper protection with varnish or coating. But let me clarify, this is extremely important for slow setting materials. This is class 2A from the classification of glass ionomers. The modern glass ionomers, which are fast setting, they reach this moment of setting reaction faster, much faster, and they are not so, let's say, sensitive to water disbalance. The wear resistance and the surface hardness of the material will improve over time with the maturation of the restoration. With the resin-modified glass ionomers, we have a little bit different setting reaction, because on top of the autocure acid base reaction that it is already available from the conventional glass ionomers, we have the polymerization of the HEMA. That is hydroxyethyl methacrylate. That's the resin that it is usually added for the modification with the resin. And this is oxidation reduction setting reaction. And then the light curing resin modified glass ionomers, they add another one, that is the light cure mechanism or light activation with the catalyst. So basically all resin modified glass ionomers that are light curing are actually with triple curing setting reaction. When we are talking about tooth-friendly materials, and we need to take a look at what it is happening in a caries lesion, we can clearly identify caries enamel, caries infected dentin, and caries affected dentin. But that is just on a picture when there is a cross-section. When you take a look at the cavity in the mouth, that it is extremely difficult to differentiate which caries dentin is actually infected and which one is affected. The affected one is just demineralized. It is not infected with microorganisms, and we can actually remineralize with certain materials such as glass ionomers. Of course, we can take advantage of the phase technology, that is fluorescence-induced, fluorescence-aided caries excavation, which under a certain wavelength, the porphyrins in the alive bacteria are glowing with different color. You can see on the screen they are glowing in a reddish color. So we can actually see not the living bacteria, but we can see where the living bacteria are because of their the product of their metabolisms, and we can remove them. But of course, it is very difficult and rather expensive to have a separate device like this. So very often we are actually relying on the fluoride bacteriostatic effect of the fluoride or fluoride ions. You can see on this slide from one of my mentors, Jan Nago, and he's actually showing the difference of the effect of two different glass ionomers because of different level of fluoride release. And you can see on the right the Fuji triage, which is actually releasing much more fluoride than the Fuji 9 that it is on the left. You can see that the colonies of the bacteria are much lower quantity. Basically, all the glass ionomers are releasing fluoride, some more, some less. But it is not so important because the glass ionomers are acting like a battery. They can release fluoride up to a certain point when they are depleted, and then every time we are taking a solution which is with fluoride ions, we are actually recharging the batteries, and they can start releasing once again. So what happens when we have an incomplete caries removal? So when we are close to the pulp and we do not want to risk pulp exposure. I am very happy to share the result of a systematic review done by Falk Schwendike, and one of the conclusions in his study and this review is that incomplete caries removal is giving very many advantages. One of them is significantly reduced risk of pulpal exposure, and postoperative symptoms are much less compared to complete excavation. There is no evidence that incompletely excavated teeth are more prone to complications nowadays. And another study that, again, that is a critical review, it's not a case report or anything like that, but this study states that GICs alone, after partial removal, exhibit durability and effectiveness, which is similar to treatment done with complete caries removal. And one can state that there is a substantial evidence that the removal of all infected dentin is not required. So we can remove partially the infected dentin as long as we seal the lesion from the oral environment. And that is the key point. We can leave something underneath the restorative material, but we have to cut the way for the supply with the needed products for the metabolisms of the bacteria, so they would not survive in the caries. So if you take a look at this case, there is a acute caries after removal of the old amalgam and caries lesion. You can see a very, very deep cavity that it is, if we do a complete excavation, we are going to definitely need to do a root canal treatment. So take a look at the borders of the preparation. All the zone, the peripheral zone is completely sealed, completely clean, so we can seal it from the outside, while the infected area is covered with high fluoride releasing glass ionomer. In this case, it's Fuji triage. This method is called internal remineralization, and we are counting on the high level of fluoride release to this affected dentin. So afterwards, after we place the high releasing glass ionomer, we can seal the margin with another high viscous glass ionomer, and then cover the occlusal surface with the composite. And then we can start monitoring this tooth. The worst that can happen is that we do endodontic treatment, but very often in those cases we are going to be able to avoid it. In another case that it is similar, you can see that this is more or less pulpal exposure. The caries is removed using a excavator, so exactly in line with the topic of the Congress. After we achieve a clean zone for the peripheral seal, we can close it with glass ionomer and then start monitoring and try to save the vitality of the tooth. Most of the cases, especially when we have molars with multiple roots, and the chance of the success of this kind of biological treatment is very high, especially in the young patients. So let's see how we do it step by step, and I will try to explain some, let's say, hints or tips and tricks that that can help achieving a better result in a faster time. So first of all, glass ionomers do not require, let's say, complete isolation. Of course, it is always easy when you can place a rubber dam and you can isolate the tooth from the oral environment, but this is very often not the case. And most of the colleagues prefer to do this just with using cotton rolls. When we do the preparation, the only thing we need to do is to remove only the infected, and even then not completely the caries lesion. Then, very often it is recommended to use conditioner, that is polyacrylic acid. I will speak a little bit more about that. But the polyacrylic acid is basically the same liquid that it is in the liquid of the glass ionomer, except that the concentration is a little bit different. The idea of using the conditioner is to maintain intimate contact, to wet the surface, to achieve better contact and better bonding, to facilitate the ion exchange between the glass ionomer and the dental tissues. With GC, we have two different conditioners. Both of them are polyacrylic acid, but the one on the left, the dentin conditioner, is 10% and is to be used for 20 seconds on the tooth, while the one on the right is a cavity conditioner that it is 20% solution, which is to be left on the surface for 10 seconds. And of course, because of the higher concentration, it has a little bit different effect. But to compare the effects of the conditioner, I would like to show you a same picture, SEM picture of edge dentin with orthophosphoric acid. That is the one in the middle. The picture on the left, that is a smear layer that it is left after the preparation with a burr. The one in the middle, that is edge dentin with orthophosphoric acid. And the picture on the right, that is the conditioned dentin after treated with dentin conditioner. So you can see that the dentinal tubules are closed. So that means that we do not open the dentinal tubules, therefore we do not experience postoperative sensitivity. But you can see on the picture on the left that the grooves left from the burrs are actually covering the whole dentinal surface and create a very, very thick smear layer. So that's why it is always recommended whenever we have burr cut dentin to use dentin conditioner or cavity conditioner to clean this surface. If we are using, for example, chisels or excavators, or the tooth is fractured, then there is not much of a difference whether we use conditioner or not. Same if the tooth is treated with laser. But as this study from the university in Leuven with a couple of my friends that did it, they show that especially when the burr cut dentin, it is crucial to use polyocanoid conditioner to remove the smear layer and to allow the glass ionomer to react intimately with the dentinal surface. Then after applying the conditioner, we have to rinse and dry. But then again, we should not over dry. We should not desiccate the dentin, because the dentin is a living tissue that normally contains water. So if we desiccate it, the dentin is going to uptake the water. It's going to take the water from the glass ionomer, and therefore there will be no proper phase to actually to achieve the setting reaction of the glass ionomer. I usually prefer to use the capsules because with them we always have the proper ratio between the powder and the liquid. They are mixed for 10 seconds and they are applied straight into the cavity, removing or let's say counteracting the biggest disadvantage that the glass ionomers they have is that they are sticky. But if we are using the capsules, we are just putting the capsule on the bottom of the cavity, trying to always extrude the material with the capsule inside, so to avoid incorporating air bubbles inside, and we overfill the cavity. The goal is always to overfill the cavity, because then it's extremely easy to do the modeling, the occlusal surface modeling. Glass ionomers are materials that can be placed in bulk, and that is their biggest advantage. Of course, there are also bulk fill composites, but they do remain composites. They do shrink. They do cause stress during this shrinkage. While the glass ionomers, they have a very, very small shrinkage, and the stress is negligible. So I always put the glass ionomer in bulk, wait for a certain setting of the material, and just to avoid giving you a correct exact number, I would tell you, look at the surface. When the surface becomes matte or becomes dull, then matte, when it's not shiny anymore, that is exactly the right time that you can do the occlusal modeling of the restoration without the material being sticky to the material. Then we can do the finishing and polishing. Of course, I usually wait for the end of setting time of the material. In the case of ECFIA, for example, is 2.5 minutes. And then I can do the occlusal adjustments. The occlusal adjustment is done with a diamond burr, with water spray, and usually done within a minute. Then some of the materials, they have to be polished. However, the glass ionomers, because of the bigger particles, they cannot be polished very well. So therefore, all the glass ionomers can be coated with a resin coating material, which is usually light curing. I will speak a little bit more about it later on, but that is not only giving us the benefit of faster working, but also giving us the surface that becomes smooth extremely fast, and it is becoming also much harder. This kind of coatings are light curing. So to summarize, why we use glass ionomers: because of the chemical adhesion, because of their sealing ability, because of their minimal shrinkage and low thermal expansion, and because they are moisture tolerant, they do not require rubber dam. One might argue that the glass ionomers do not have a higher bond strength to the dentin or the enamel, but that is irrelevant, because when we are looking at the percentage of annual failure rate, you can see that the glass ionomers are performing as good as the best adhesive system that it is usually two-step etch and rinse adhesives. Again, if we have a little bit of excess moisture, it will become part of the restoration itself. When the materials fail, usually when we have poor placement technique, when there is little or no isolation, when we do not protect against the water uptake, when it is desiccated during finishing with the patient that has little or no saliva. Here you can see the difference between glass ionomer that was covered initially and the one that it is not. The one on the left, it is not covered. The one on the right, it is covered immediately, and you can see the big difference after 3 and respectively after 6 years. Different cases, especially for class 5 glass ionomers, are extremely well indicated because of very many reasons, but mostly because of not proper isolation, difficult isolation, or not enough enamel that it is available for bonding with adhesive resin composite. One of the other main application of the glass ionomers is protection of the newly erupted molars, even during the stage that are partially covered with gingiva. So in both of those cases, we can use their moisture tolerance to protect the surface, and then every time we ask the patient to brush with the fluoride toothpaste to recharge it with additional fluorides. What are the limitations for the cavity size? They are indicated for class 1 and class 2, and when we have class 2 preparation, it is half of the intercuspal distance. Very often we have the scenario that we can use the best of both worlds. When we are talking about sandwich technique, then we are using a glass ionomer to seal the margins when they are in cement or in aprismatic enamel, and then cover the surface on top with composite. And one of the things that we should try to remember is that the contact point with the adjacent tooth should be done with the composite because of it is more wear resistant. So when the glass ionomers are the first options, especially in the pendodontics with gerodontology, with the incomplete caries removal, deep cavities, high-risk patients, high risk of caries, when we need a temporary solution, and especially when treating MIH and partially erupted teeth as a fissure sealant. So let's talk a little bit about glass hybrids. I will try to explain shortly what is the difference between the glass ionomers and the glass hybrids. But basically, glass hybrids is a unique combination of filler composition with different kinds, with filler particles with different sizes and different reactivity. So we have the glass component and then the hybrid component. The hybrid component is mostly with different glasses, with different reactivity of the glasses, but also different particle sizes. As a result, we have the glass hybrid. The glass hybrid is always two components. One is the glass hybrid filling material, and the other one is the resin coating material. So always two components. So what is the difference between the glass ionomers? The glass ionomers, they have in the cement powder, they have 4 aminosilicate glass. and some of them they contain also polyacrylic acid in the powder, and in the cement they have polyacrylic acid in the aqueous solution. While the glass hybrids, they have additionally high molecular weight polyacrylic acid in the powder, but they also have new highly reactive fluoroaminosilicate glasses in the powder. So basically the liquid is more or less the same. The difference is in the powder. On top of that, there is another component that is the coating liquid, which is usually a mix of methacrylates, which are filled, usually with smaller particle fillers. In the case of Equi, we are talking about 40 nanometers silica fillers, and we also have a photoinitiator to start up the setting reaction. One of the things that it is worth mentioning that this is also containing multifunctional methacrylate monomer, which is actually self-adhesive. So we do not need to place any kind of adhesive underneath the coating. So to summarize, the glass hybrid technology is because of intelligent particle distribution, control particle interaction, and becoming increased wear resistance because of the coating that it is applied on top of that. You can see the different sizes of the filler particles. The normal ones are approximately 25 microns, but we have new ones that are very highly reactive, that are 4 micrometers, and they are actually releasing more metal ions, which are increasing the cross-linking with the polyacrylic acid, thus making the matrix a little bit stronger. We have also high molecular weight polyacrylic acid, which is making the cement matrix stronger and having a better flexural strength, better flexural energy, and also superior handling. When we are using the coating on top of that, we are placing the coating after the initial set of the cement. So it is penetrating in the depth of 50 microns. So you can see on this slide that the coating not only sits on top of the restoration, but also penetrates in the voids underneath, making the material stronger. But then, as any other material, it is going to wear off. Usually, when this material wears off, it takes 6 to 8 months. And then, by that time, the material is already maturated. So it becomes stronger, harder, and becomes harder because of the ion exchange with the saliva. What else is changed? It is because of the new particle size that they are smaller. The difference of the refractive indexes between the fillers and the matrix is smaller, making the material a little bit more translucent, a little bit less opaque. And that was the biggest issue with the glass ionomers, that they were always more opaque than the dental tissues. So you can see on this slide that comparison between the old version and the new version is improved translucency. And that is only from the aesthetic point of view. But moreover, everything from the physical properties of view is also improved. We have much bigger flexural strength, we have bigger compressive strength, and we have much less wear, meaning bigger wear resistance, sometimes even comparable with the ones of the composites, which is something unusual for the glass ionomers and the glass hybrid. So basically, ECRI is acronym. It stands for easy, quick, unique, intelligent, aesthetic, and all those qualities I already explained. But probably as a practicing dentist, the most important feature is that it is moisture tolerant, it is bulk placement, Therefore, the whole procedure is approximately 3.5 minutes from start to finish. And aesthetic, I will show you a couple of cases just to show you that this aesthetic, especially in the posterior, is not as what we used to think of glass ionomers. Recommended indications are usually extended compared to the glass ionomers, meaning we have class 1, class 5, but also class 2 restoration with much wider cavity size. So with the glass ionomers, we have to stay in the, let's say, in the limit of half of the intercuspal distance, but here we can just stay 1 millimeter away from the peak of the cusps. So that is the one thing that we should avoid. They are also suitable for the root surface restoration and also for the core buildup with severely damaged teeth that are going to go under the indirect restorations. Very, very fast, I will try to show you the cavity size. We should stay away, as I said, at least 1 to 1.5 millimeters away from the peak of the cusp. We should use proper matrix systems and proper preparation design. So the matrix system should be concave, should be convex, should be anatomical, should support the material, and the preparation should avoid any sharp angles and lines that are places that the stress is concentrated. So as long as we follow these rules, we will have results like the picture on the right. What happened on the picture on the left? It is that easy. We have it was used a flat matrix. Then the bulk of the material of the glass hybrid was not supported. So in all those cases, every time when we are using flat matrix, we are having a marginal ridge that it is subject to be chipped off, and therefore leads to foot impactation and complaints from the patient. I will show you a couple of cases, not for any other reason, but to show you the difference, especially with the aesthetic point of view, because I will speak very, very shortly also about the longevity of the restorations. Those are clinical cases of Professor Kütük from Turkey, and she has a very nice documented cases like this one, when the caries with incomplete partial caries removal after using the cavity conditioner, rinsing, and then placing the glass hybrid in bulk. It was waited till it's become dull, then it was adjusted occlusally, checked with articulating paper, then applied the resin coating, which is afterwards light cured. And you can see the aesthetic result on the last two pictures. And another case that it is similar. As you can see, again, no rubber dam, removal of only infected tissues, rinsing after cavity conditioner, applying the glass hybrid in bulk, adjustment, and then covering of the occlusal surface with the resin coating, which is afterwards light cured. And again, you can see you can judge the aesthetics. And a third case, similar to this one, same procedure and more or less the same result. I would always argue, if someone would say that these are not aesthetic results, we should always think of, is this the best for the patient? Is this the most important for the patient, the aesthetic of the posterior teeth? I would question that. So, one more thing that I would like to cover very often we have the opportunity to speed up the process of setting reaction of the glass ionomers and the glass hybrids with adding extra heat. Usually we are adding this extra heat with the help of the light curing device. The only thing that we should check is if our light curing device is producing enough heat. And this we can check on the tip of our fingers. If by 10 seconds we sense the heat that comes from the light curing unit, that means that it is powerful enough to actually provoke the thermal curing of the glass ionomer or the glass hybrid. So in those cases, we should reach the light curing device should emit at least 50 degrees Celsius of heat. Then the material is going to set faster and it's going to become stronger. And we will save a little bit of time. It is important to underline that this heat curing or thermal curing should be done while the material is still setting. This is not the light curing stage with the coating, resin coating. This is done while the material is still setting. Some would ask if we are going to overheat the pulp or we can damage the pulp. But then we have to remember that glass ionomers or glass hybrids are endothermic setting reaction. That means that when we apply the heat, they're actually absorbing the heat to set up. Or in other words, if when they are setting, they are not actually producing heat, but vice versa, they are uptaking the heat. Still, I would not recommend to use the thermal curing when we are extremely close to the pulp. And now, probably the most important one when we are talking about longevity, do we have evidences of the clinical success and longevity of those restorations? There are plenty of studies published, some of for the period of 1 to 6, 7 to up to 10 years with Equia Fill, and with Equia Forte, which is the new material, we have studies that are published with extremely good results up to 4 years. So I do not have the time to show all the clinical evidences, but they are available. I can provide the links in the Q&A section afterwards. So to summarize, the glass hybrids are wear resistant, they are true bulk fill materials, they have extended indications, and therefore they are long-term restoratives. And as a summary, I already told you the cases that we should choose glass ionomers, but what are the cases that we should choose glass hybrids? When we have a little bit more bigger aesthetic demands, when we need a faster or stronger restoration, when there is no isolation possible, when we need a long-term solution, when we are treating medium-sized cavity. And then when we have a higher aesthetic demand, when we need longer-lasting restoration, but we can do a proper isolation with the patients with lower caries risk and proper oral hygiene, and most very often in larger cavities, including fiber-reinforced composites, then we can turn to the resin composite. So that was all I wanted to show you. I would like to thank you for your kind attention. You can always ask me questions if you have on my email, or I will stick around to try to answer the questions just now. Thank you very much.
Oh, thank you very much, Dr. Raduslav. I try to work here with some translation, summarizing some of the points that I could translate, but I think it was great. Thank you very much for your kindness. We have some questions, yes, but we will change for the link. So the link that is for the YouTube where the students, the expectations can go is here. So I'll send you the other link now, so we can go to the next room. Okay?
Yeah.